Dear my friends, I am Isaac Chinnapan from Johns Hopkins All Children's Center, United States. First of all, I would like to thank you, the AMSECT leadership, the organizing members, organizing secretary, and the scientific committee members for giving me this opportunity to participate ISECT Virtual 2021. And also would like to thank all my friends across the world, especially in India, those who are attending this meeting. So my topic is the present and future of neonatal perfusion. There is no disclosures. The objectives for this presentation is current and future concepts about the neonatal perfusion. When we talk about the current concepts, the very important objective is the review of standards and guidelines for neonatal perfusion. The reason I'm mentioning about the standards and guidelines is that is the one which is giving you an evidence-based approach to support your technique, to justify whether you are doing the right thing or a suboptimal technique. Second thing is the future of neonatal perfusion. When we are talking about the future, review of the possible advancements in neonatal perfusion. So when we are talking about the present and future neonatal perfusion, there are a few things we have to bring into our thoughts. Huge variations in clinical practice. If you see 10 institutions, probably they may have 10 different type of protocols, 10 different types of approach, 10 different types of preferences. Priming composition is historically, if you see, there will be a huge variations in the priming composition. Blood utilization and transfusion triggers. Again, it's a huge debate for the past 20, 25 years. Maintenance of fluid dynamics, COP, that is colloid osmotic pressure and osmolarity, which is equally important like any other concepts of like a flow, PO2, saturation, idealism of perfusion. Just like this, the concept of the fluid physiology also very, very important. But unfortunately, we don't have any online, inline monitoring devices to check these very important fluid dynamic components like COP and osmolarity. Some of the blood gas machines gives you the osmolarity, but on the protein component or the colloid component, the colloid osmotic pressure, we don't have any devices as of now in our current clinical practice. Understanding the importance of hemic and non-hemic variables is another important concept. While we are giving the more importance to the hemic component, we are not giving that much importance to the non-hemic variables during cardiopulmonary bypass. Different approaches in defining the adequacy of perfusion. Adequacy, when we talk about in the older days, people used to talk about good venous saturation or lower lactate levels. But now the concept, now the current era of delivery of oxygen, there are so many variables it's involving to justify what is meant by the delivery of oxygen, adequacy of perfusion. Then what about the future? When we talk about the future, first we have to define the future. It's 10 years, 20 years, 50 years, or 70 years. Next 10 years or more. So my definition of future is neonatal perfusion. What is my concept of looking the future is I'm looking just for the next 20 years, what could happen in the next 20 years. Because if God gives me good health, probably I could live for the next 15, 20 years. So whatever is happening in the next 15, 20 years, if I would like to think about that and in whatever the possible way to do the best way I can learn those things and encounter myself with all those advancements. That's what my aim is now. So whatever my predictions, by my experience, I'm going to pointing out in this presentation or could occur in the next 20 years. The current concept or present concept in the neonatal perfusion is the hemoconcentration plays a huge role. As we are doing the blood prime, balanced hemoconcentration is the current standard of care. We need to do the concentration. The hemoconcentration, starting from the priming, that's called as the pre-balanced ultrafiltration, that is a priming ultrafiltration to achieve the physiological perfusate, like electrolytes and all the other components. It should be in the physiological limits. And defining the physiological perfusate is another component. Osmolarity, oncotic, hemic, and non-hemic features of the perfusate should be within the physiological limits. Selective MUF is another concept of the current concept in the neonatal perfusion. In the older days, always we used to think the MUF is an ornamental technique to our neonatal population, but since 2015, there was a decline in achieving the modified ultrafiltration because either whether we have this clinical significance, clinical benefit, or just we are spending the time post-pump. But again, hemoconcentration is concentrating the blood. By doing a technique, if you're diluting the patient, that means there is a problem in the technique or the patient is not ready for the MUF. For example, if the patient is severely bleeding, that is a time we have to concentrate on more coagulation factors rather than spending 5 to 10 minutes on modified ultrafiltration. So the modified ultrafiltration nowadays is the definition is the selective MUF. Once you're coming off bypass, assess the patient's hemodynamics, assess the clinical significance of modified ultrafiltration, then proceed. So hemoconcentration is one of the major concepts in the current era of neonatal perfusion. The next one is myocardial protection. Over the years, there are every conferences, every debates, every surgeon's conference, every perfusionist conference, you can see there will be a topic on myocardial protection. Did we find the final ideal myocardial protection concept or composition of solution? Not yet. Now we are in the Del Nido era of single dose safe cardioplegic arrest in neonatal perfusion. But how long is safe arrest, or that is the single dose is enough? Those concepts needs to be explained or justified. Does Del Nido ideal for all pediatric patients? Custodial and other solutions with numerous compositions also exist in the field. And all cardioplegia solutions, there are so many publications to support about their future or about their compositions. The past 20 years, never-ending debate. New compositions keep coming. Reference-based justifications with evidence-based references or support is a constantly keep on going. So the myocardial protection is another area in the current present standard of neonatal perfusion. The next one is the selective cerebral perfusion. We talked about 40 to 80 ml per kilogram per minute. Antegrade selective cerebral perfusion gets its superiority over retrograde counterpart. Use of cerebral and somatic NIRS is a standard of care. If you're not using this one in your clinical centers, you are compromising the safety and standard of care. Deep hypothermic circulatory arrest, still an ornamental tool, but lost its credibility. Why should we punish the brain for the cardiac defect? So this is another area of concept that we should consider in the current present neonatal perfusion concept. Mechanical circulatory support. Encouraging outcomes with PD-Max and SHIMAC hardware, HeartMate 3 and Berlin Heart. Continuous flow of mechanical circulatory support versus pulse-rail fluid devices. Again, there is a debate. Initially, we thought the pulse-rail devices are better than the continuous flow, but now the concept and the evidence-based data shows that the continuous flow is better at certain points before switching to the pulse-rail devices, especially in the neonatal population. ECMO is considered as a universal supporting system, the highest number of supporting systems running all over the world for the recovery of the failing heart and or the lungs. ABO incompatible transplants, reducing the waiting time and frequent availability for the donors and neonatal heart, and it's playing a huge role in the current standard. And another concept of the present in neonatal perfusion is standards and guidelines for the neonatal perfusion. AMSEC Pediatric Congenital Standards and Guidelines established in 2019. CCPs has the option to request for the per capita budget from the administration to invest on all required safety devices and disposables to ensure the best possible care and standard of care. We need surgeons to support to acquire many quality devices and disposable to provide the best possible care. Again, this is a challenge. When we get a job and going to the different centers, we are talking about our compensations. But what is the facility we have? What the institutions could provide to provide the best possible care to our patient population. So those concepts we should consider as part of our compensation or as a part of our job hunting when we are going and selecting different institutions to work among the other people. So we can see a few about the future of neonatal perfusion, the development of evidence-based guidelines, something which is consistently wrong, that is doing a wrong thing correctly or a correct thing wrongly, both are unacceptable. So the evidence-based guidelines will guide you how to do, why to do, what to do. I mean, doing the best technique and providing the best possible care to our patient population. So the resource is the standards and guidelines. So when we are talking about the future in neonatal perfusion, make sure difference. You have a standards and guidelines which is supported by the evidence-based practice in your respective institutions. The next one is ECPR, extracorporeal cardiopulmonary resuscitation, which provides the promising results, may have advanced options and approaches in the near future. The next concept in the future, we could predict a more precise management of electrolyte imbalances, balanced isotonic solutions, washing solutions to achieve more physiological perfusion. In 2017, Gary Christ from St. Louis brought the concept of 0.45 NaCl, that is abnormal saline, with the 50 milligrams of sodium bicarbonate as a washing solution during bypass or in the prime to reduce the sodium, which we are getting a very promising results as a by using the 0.45 NaCl as a pre-buff solution or washing solution. The concept which is very important is in the future, coordination between hemic, non-hemic, osmotic and oncotic to preserve the fluid dynamics, prevent fluid shift, and to provide the better organ function. The surgeon could do the better surgery, but if we compromise the fluid dynamics and fluid physiology, the patient will end up with organ dysfunction. So more precise management of the electrolyte imbalance is one of the important components that probably our future perfusionists will focus on. The next one I'm predicting is the synthetic blood products. You know, the cardiac surgery, even though it accounts for 5 to 10% of all the other cardiac procedures, other surgical procedures, the blood component utilization by the cardiac surgery is over 80-85%. So the synthetic blood products, which can carry oxygen, eliminate carbon dioxide to control bleeding and better long-term post-op outcome could be possible in the near future. Endothelial layered CPP circuits, which is otherwise called as physio-compatible circuits. We are having the coated circuits now, but in future we could have the endothelial layered CPP circuits. So the CPP circuits could mimic just like the vasculature. Nitric oxide utilization is another area of research that the latest findings that shows a better neurological outcome by utilization of the nitric oxide during cardiopulmonary bypass in the neonate infant population. When we talk about the current concept in the clinical practice for the neonatal perfusion, and the concepts of the future of neonatal perfusion, one of the concepts what I would like to include is, what about the future of perfusionists in developing countries? Do we establish regulatory education and certification boards to certify our current perfusionists or future perfusionists to serve in this noble profession? Is everyone starting educational institutions, or do we have a regulatory board, specifications, visit to evaluate an institution, to talk to the students whether they are getting good exposure, clinical experience? Are we promising to our current perfusionists or our students for scope of practice of this noble profession? If they are getting out of the school, how soon they are getting a job? If they are getting the job, how is their compensation? How is their income? Is there a competitive, or we are oversaturating this profession? These are all the questions to our ISET office bearers and all the members or office bearers of the professional associations, how we are protecting our profession and the professionals for the future. ISET Virtual Conference 2021, the other day when I was seeing the brochure, the top ISET coordinate was saying that trending with the future. And the motto or the idea of this specific session among the 4 speakers is the learn from the masters. So when we keep both the things, the trending with the future and learn from the masters, I would like to put a few questions. Do we have a strategic plan to monitor and maintain an evidence-based medicine or evidence-based clinical practice in our respective institutions? Would you all consider the physiological matrices, biochemical variables, and oxyfluid factors to ensure the comprehensive approach to accomplish a standard of care? You have oxy and fluid specific calculations like delivery of oxygen, DO to I, osmolarity, osmotic pressure in your clinical practice. Dear friends, if you are looking for a take-home message from the session, you could consider the evidence-based practice includes sharing our knowledge and thoughts to refine our clinical practice through which to provide the best possible care to our patient population. Share our expertise and thoughts with reference to the evidence-based medicine to provide the best possible care to our patient population. Again, trending with the future, analyze, assess your current trend for a promising profession and professional practice. Learn from the masters. I respectfully remember the institutions that given us education, Christian Medical College, Medtronic in the older days. And nowadays, so many institutions have come up. But again, the teaching institutions and our mentors who gave us the education and a promising future. But my question now is, do we able to do the same for our current and future professionals? That is also one of the concepts we have to take it as a take-home message from Virtual Conference 2021 of ISET. So by considering the future, by considering the present, we have a lot of things to do the best possible care to our patient population. But the one thing is very important is that protecting our profession as well, and the young perfusionists and the perfusion students should have the hope they are in a great profession to doing the best possible care to our patients' population. Before ending this presentation, dear friends, please accept a sincere appreciation and greetings and wishes from the Pediatric and Congenital Heart Center and Pediatric Perfusion team at the Johns Hopkins All Children's Hospital, Baltimore. Thank you for your presence and patience.